welcome to another podcast. Today we're going to continue with pharmacology, and we are going to look at glucagon. Now, the indications of glucagon, believe it or not, still has it used for the treatment of hypoglycemia. In adults, that's generally less than 4 millimoles per litre, but obviously it can be around the 4 mark, and symptomatically that you can give glucagon. We are now able to give glucose first, and then really only use glucagon if IV access is not possible, which works very well in our favour given our demographic. And the administration of glucose is, it's a lot more rapid in its treatment that we can look at later on. It's also been written for a while that glucagon can be used in the management of anaphylaxis if the patient is on beta blockers. Okay, so glucagon may be useful, but you will need to consult an MO before you even consider doing something like that. Now, the concept of using glucagon in anaphylaxis may be a little bit foreign to people, and to tell you the truth, it's one of those ones that's really only been proven strongly in case studies. So it's not a hard and fast policy or doctrine, which is so. Glucagon has been used for things like beta blocker overdoses and calcium channel blocker overdoses for a while in order to increase cardiac output. Okay, that's the whole idea. Now, the advantage glucagon has is that it has positive inotropic and positive chronotropic effects without going through the beta androgenetic stimulus. Okay, so it actually binds with your adrenal systase, mixes with your CAMP cycle, and stimulates an increase or an influx of calcium into the myocardial sites, and that in itself increases its contractility. And by increasing its contractility and its rate, it significantly increases output, which is obviously quite effective when you're dealing with a patient who's hypovolemic or hypertensive for that matter, in maintaining a greater MAP in order to aid in perfusion. Okay, so it supports the blood pressure. Now, its use in anaphylaxis is for that alone. Now, its effects on the bronchies are very minimum, so there's very weak evidence to suggest that it has much effect on the bronchies. It certainly is not a bronchodilator, but it has got some weak evidence to show that it helps with bronchospasms. On top of that, the use of glucagon is starting to be looked at a little bit more, in a little bit more evidence of being used and having positive anti-inflammatory properties as well, which can help in anaphylaxis. So like I said, that's how the whole thing works. It's been used for beta blockers overdose and calcium channel blocker overdoses for a while. It has had case studies of effectiveness in anaphylaxis on patients with beta blockers because it bypasses the beta receptor and still causes that increased inotropic and chronotropic effects. But realistically, call for advice if you're ever in a situation like that. Just know that that's the way that glucagon works. Now, looking more into glucagon, we'll look a little bit at its pharmacokinetics. So nice and simple, its absorption rate is quite slow, which is the reason why it was always an absolute bugger to use in hypoglycemic cases when we knew full well that it probably wasn't going to be that effective for our patients. So its absorption can take around 10 minutes. Really, if you haven't seen an effect within 10 minutes, then if you haven't already got IV access, then you've got to push for it and probably go IO and start getting glucose in that way. Once the drug is in, it takes around 30 minutes before it reaches its max glucose concentration. So after 30 minutes, that's where the peak BGL will be at, and then you can expect that it's probably going to go down from there. So the patient needs monitoring after that. When it goes IM, we have a few different areas of metabolism. So it actually gets broken down in the plasma itself, then it gets broken down further in the liver, and it even gets broken down by the kidneys as well. So it burns up relatively quickly for an IM drug, and it has a half-life of about 45 minutes. When we look at pharmacodynamics, pretty much if you have an understanding of glucagon, the hormone, then you're sort of going to know how it works. So when glucagon is released by the alpha cells in the pancreas, or it's given artificially by us, it has a series of effects on different organs in the body. And we've already looked at the heart, so we're not going to go too much into that. It affects on the brain is it actually reduces your food intake, your appetite, and your willingness to finish your meal. Okay, which may seem counterintuitive. The reason is it actually wants to use the stores that you've got instead of having to worry about producing glucose or metabolizing glucose from food sources. It's much faster to get it from already reserved areas. The release of glucagon also causes a bit of insulin to be secreted. Not as much as obviously a glucose spike, but it still has a little bit of secretion. Now, its main role sits with the liver and the adipose tissue. So it increases the amount of glucose production. Okay, so glucogenesis will actually occur, and that is where glycogen stores are actually broken down and glucose is released. Okay, and that's where we get that glycogen lysis effect as well. On top of that, we also have an increase in lipolysis, so fat is broken down, especially your brown adipose tissue or adipocytes are broken down, and they will actually release glycerol, which can come back in, and then they can go through a process known as glucose eogenesis, which is the production of glucose molecules from external sources, like your amino acid breakdown, keto body breakdown production, that sort of thing, to release glucose molecules. So all these things are occurring just because of the release of glucagon. And obviously the end goal is to increase serum glucose levels, so the amount of glucose that is found in the blood itself. Now, it's a relatively safe drug, and there's very few contraindications. So the old hypersensitivity is one that sounds a little bit weird, but it's more hypersensitivity to the additive agents or the body that's keeping the glucagon stable itself. So you won't know if they're allergic to it or sensitive to it, but the recommendation is if you give it and a rash and that sort of allergic type reactions flare up, then it gets recorded and it doesn't get administered further or again. Now, the other contraindications are specialized tumors or neoplasmic growth. So phemochromocytoma is a hormone releasing tumor that mimics the adrenal glands. So you actually have a massive release of catecholamines. Now, the use of glucagon can actually stimulate the unregulated release of catecholamines from the pheochromocytoma, and therefore having pretty nasty side effects. Same with your insulin lomas, and even your glucagon is a contraindication if you're using glucagon as a diagnostic tool, which we're not. Now, on top of that, there's just a couple of cautions, mostly associated with people with cardiovascular diseases or cardiomyopathies themselves, because of its effects on the inotropic and the chronotropic effects with the heart. There's just a few bits of cautions if you are administering it, just to monitor the heart, make sure arrhythmias don't come in, or make sure they don't have a spike in hypertension. Now, adverse effects, quite simple. The main ones that you will see will be nausea and vomiting. You can have cases of a small rash occurring, and in certain population you will get the tachycardia and increased blood pressure that we spoke about. As far as drug interactions go, there's again not a lot. There's no complete contraindications for drugs, okay, but there's a few drugs that are commonly used that have some pretty severe interactions, so you just need to watch out for them. So beta blockers is one of them. So if someone's on beta blockers and you're giving glucagon, they have a chance of having that increased pulse and increased blood pressure like other people do, but a lot of the time people are on beta blockers because they want to control hypertension, meaning an increase in blood pressure is more likely to have negative effects. Now, if someone's taking indomethacin, which is a pretty common anti-inflammatory, the administration of glucagon may have no or even a negative effect on the hypoglycemia. Okay, so glucagon can actually lose its ability to raise glucose and can even cause further hypoglycemia if the patient's taking indomethacin. So it's definitely err on the side of caution if someone's on that. Now, generally speaking, a class of anticholinergic drugs, if you give them with glucagon, then you increase the likelihood of them having the gastrointestinal side effects. So nausea, vomiting will pick up. Someone's on warfarin, glucagon increases the anticoagulant effects of warfarin, which can be quite dangerous. And if you are giving it to someone who is on insulin, so taking a slow release insulin, then the insulin levels can actually counteract the glucagon. Okay, so quite often you will need to give the sugar, occupy the actual insulin, and then you can give your glucagon over the top of that. So glucagon is most effective for people who are on insulin, and that's the reason for their hypoglycemic state. But if someone's on a slow release insulin, then it's still going to be in the system when you're administering glucagon, and it can just degrade its effectiveness. That's pretty much all you need to be aware of. Okay, a few additional take-homes. When you're dealing with hypoglycemia and glucagon, that sort of thing, it is always best practice to get a BGL, so then you can rule out other things that cause similar symptoms. Okay, but in the event that you cannot get a BGL, and you may think, well, when the hell is that possible? Okay, there are times that a person can be shut down due to activity, due to cold, due to something like that. The blood, it just doesn't come out that well. Okay, we also know the environments that we work in. Sometimes getting a BGL is difficult. So you can use your clinical skills, look at the symptoms, look at what the person's been doing, and if you feel like it's hypoglycemia, then give glucose. As mentioned, only administer glucagon if we don't have IV access, and that is particularly important for military personnel, given the reasons why we get hypoglycemia. Okay, working on civilian population, diabetes, insulin overdose, glucagon's quite effective. Glucagon will only work if there is glycogen stores in the liver. Okay, if there's no glycogen stores in the liver, glucagon's not going to work. So in people who have gone through starvation, malnourished, alcoholism, they've been exposed to prolonged periods of cold, and therefore they've burnt up all their stores, or they've been working exhaustively with very, very little food intake, then their glucose stores is going to be diminished, and they're likely to have very little to no hepatic glycogen stores, meaning glucagon won't really work. Often in these cases, that sort of hypoglycemia is a precursor or causative agent of seizures or cardiac arrest. So remember, whilst you're treating the seizures or a cardiac arrest, if it is hypoglycemia, you must fix the hypoglycemia as well as manage the other condition. Okay, that's all we have for glucagon. Quite an easy drug, a drug we don't often administer within the military. However, it is within our protocol, and if you need to administer it, you've got to know why you administer it and the effects that you should see after administration. But that's it for this one. Hopefully you learnt something, and until next time, take care.